So what happens in myasthenia gravis is some antibodies are formed which destroy or which affect that nerve and muscle connection. So in neurological terms, at times it is called a neuromuscular junction disorder also. So it is an autoimmune disorder which affects the connection between the nerve and the muscle.
There is a gland inside our body which is located between our breastbone and the heart, and this is known as thymus gland. Now, this gland is involved in development of immunity, and it is believed that this is the source of the antibody production in layman terms for myasthenia. And therefore, there have been studies which show that if you are able to remove this gland by a surgical procedure which is known as thymectomy, then you might be able to help the patients of myasthenia gravis by essentially trying to cure them. Welcome to this podcast. Today we are going to talk about a very rare disorder, but a very serious disorder known as Myasthenia Gravis. I am Dr. Belal Bin Asaf. I'm the Director of Thoracic Surgery at Medanta Super Specialty Hospital, Noida. And I have with me here Dr. Kapil Singhal, who is an eminent neurologist and the Director of Neurology at Medanta, Noida. So welcome, Dr. Kapil.
Thank you, Dr.
To this
Belal.
program. We treat so many patients of myasthenia gravis, and we've been doing that for over a decade now. Let us start with the basics. What is myasthenia gravis, Dr. Kapil, for people to understand in normal language?
So myasthenia gravis appears to be a very complicated or unknown sort of a term. Basically, it's an autoimmune disorder. So we have, when we do any function, there is a nerve which leaves a signal at a muscle, and then when that signal is taken to the muscle contracts. So what happens in myasthenia gravis is some antibodies are formed which destroy or which affect that nerve and muscle connection. So in neurological terms, at times it is called a neuromuscular junction disorder also. So it is an autoimmune disorder which affects the connection between the nerve and the muscle.
So, Dr. Kapil, how do people with myasthenia gravis present to you? I mean, what are the symptoms of myasthenia gravis? I've often seen many of these patients come to us after a long period of time when they have been misdiagnosed as something else. So, can you explain to normal people what are the symptoms that one should watch out for in case of myasthenia gravis?
See, usually, as you said that the diagnosis can be delayed, it is because the symptoms can be very vague. And many a times at the initial onset of the symptoms, patients end up consulting many different specialities. So the usual symptoms are, let us say, double vision. Patients start seeing double vision, or there is some drooping of the eyelid, that one lid goes down. Usually it is the one lid which goes down, and later on it can be involvement of the other lid also. And these things keep on fluctuating. At times you're good, at times you're bad, and you're not able to understand whether you're really having these symptoms or it's just a phase of your mind. At times you can have some difficulty in speaking. Your voice can become nasal. It appears that you are speaking from the nose.
Yes.
At times you can have some difficulty in swallowing also. So nothing appears to be neurological. You can go to an ophthalmologist, you can go to an ENT person, and you end up having many tests, but we are not able to reach the diagnosis in the initial phases many a time. And these are not the only symptoms, they can worsen also.
Yes, you very rightly said. A lot of patients come to us, Dr. Kapil, and they say that they all started with a very vague kind of neck pain and difficulty in neck movements, and sometimes the larger muscles are also involved. So can you elaborate on those symptoms which the patient's family can understand?
So again, when the larger muscles, when we are talking about large muscles, we are talking about the muscles which move our arms, muscles which make us walk, muscles which make us get up from the sitting position. So our initial symptom can be fatigue, and the problem is we all get fatigued after a brisk run or climbing 2 flights of stairs. You get fatigued, but what happens in myasthenia gravis is that fatigue comes at very early levels of activity. So for example, say I can climb 4 flights of stairs, but if I am getting very tired after a single flight of stairs, something is wrong. Or what you see is that you start restricting your activities. You're avoiding to climb the stairs, you're avoiding getting onto some high steppage foot, you have difficulty in keeping objects above your head, you have difficulty in lifting some heavy objects. So if these symptoms are there, they tell us that it is involvement of larger muscles also, and it is something which needs medical attention as soon as possible.
So, Dr. Kapil, we spoke about the symptoms, uh, but how common is this disease? Is this a common disease? It sounds scary because you're not able to identify it in time and it can have problems. But how common is this disease?
So, myasthenia gravis is not a very common disease. Prevalence, that is, any number of patients which are existing in the population at that point of time, is around 15 to 20 per 1 lakh population. But if you just convert the numbers into the total population, let's say Delhi, Noida, or surrounding regions, the number will be significant. The problem is still many patients in villages where medical facilities are not available, where symptoms are not recognized, still go undiagnosed. When we are sitting in a tertiary care hospital, any disease which is rare is not rare for us because we are seeing them commonly.
So I think that's a very important message. When you sit in a high tertiary care center, these diseases which are supposedly uncommon become a common parlance for you. So I'm sure
Exactly.
you have seen and treated so many patients of myasthenia gravis. And once you know that this is such a grave disease, people should understand what are the complications of this disease if it gets unnoticed or the treatment is delayed for some time.
So the initial symptoms can be double vision or some swallowing difficulty, and you can progress to involve weakness of legs and walking difficulty, lifting arm. But many times, what happens is that the weakness worsens fast or progresses gradually, and you are not able to swallow at all. You start having cough, which is just because your saliva is going into the lungs. You end up having chest infections. You develop weakness of the muscles which move our lungs, and it can even lead to difficulty in breathing so much so that you can need ventilatory support, and in that case we call it as myasthenia crisis. So this is what happens, that many a times we see the patients who have come to us with breathing difficulty on ventilator, and then we call it as myasthenia crisis, and that times the diagnosis is difficult, the treatment is difficult, the management is difficult. So early recognition is important, and this is something which helps us in managing patients better.
So very rightly said, Dr. Kapil, because sometimes the primary presentation is myasthenic crisis because the patient has had symptoms for so long, and because of the vagueness of the symptoms and inability of people to diagnose it correctly, these patients may land up into severe problem like myasthenic crisis, when they land up in ICU and ventilators, and of course, when in this stage, it will have a lot of problems. So, how do you diagnose myasthenia? If you have a patient who you suspect that could be a myasthenic, how do you diagnose myasthenia gravis, Dr. Kapil?
So the most important thing is that you have to have suspicion that the patient can have
Very
myasthenia
rightly said.
gravis. So if anybody has, let us say, double vision, drooping of eyes, some change in voice, some difficulty which is restricting your activities of daily living, it needs to be consulted. A recent patient whom I saw was having some symptoms for last 2 months, and he was not diagnosed. He came to us, we talked to him for 15 minutes, and I told him that probably you have myasthenia gravis.
Yeah.
So what I'm trying to say is a detailed history and clinical examination is something very important.
Absolutely.
If we have suspicion of myasthenia gravis, we have certain blood tests which can be done. It can be some blood tests to diagnose those antibodies. It can be some neurological tests to confirm the diagnosis. And beyond that, we need a CT scan which looks at the thymus gland. It's a gland in the chest in which there can be something called as thymoma or enlargement, which is very commonly associated with myasthenia gravis. So, clinical examination, few blood tests, few neurological tests, and depending on that, we can go for advanced imaging like CT scan also.
Very correct, Dr. Kapil. I had a patient very recently. This gentleman from Srinagar was having difficulty in swallowing, and as you very rightly pointed out, that a lot of these patients go to associated specialties like ENT to assess swallowing, and they were not able to figure out what was happening with him. Somehow, he came in contact with me, and when I saw and our neurology team saw, they realized that you told about nasal intonation of voice. That was very prominent. So we evaluated him and we found that he was having myasthenia gravis. So if I just repeat it for the sake of completeness, so you do some blood test to try and identify certain antibodies and other things. And apart from that, you do what is known as a repetitive nerve stimulation test.
Exactly.
And of course, you need a MRI brain and of course and a CT scan of the chest also, because many of these patients are associated with enlargement of thymus gland or a tumor of thymus gland, which is known as thymoma. So when you diagnose these patients and when they come to you, a lot of people are really not aware about that this is somewhat of a treatable condition. And so therefore, how do you start treating these patients? What are the different aspects of treatment?
So the first thing is we have to diagnose, and the most important thing is that the treatment depends on what stage of the disease patient comes to us. Few patients who have only some ocular symptoms or eye symptoms, we just give them some symptomatic treatment and symptoms improve. Most of the patients, or rather 50% of the patients who have only eye symptoms, can progress to involve other muscles also. So as we know, it's an autoimmune disorder, we have to take care of the immunity part. We have to give some immunosuppressants, which can be steroids, which can be other medications, and we have some injectables also. So I specifically mentioned steroids because it appears to be a scary medication, but when it is required, it is a life-saving medication.
Absolutely.
So this public perception, oh, steroids we are taking, it will be harmful, that call has to be taken by your treating doctor.
Yeah.
Another thing is, most of the patients who come to us undergo a CT scan of the chest, and they can benefit from a procedure called as thymectomy, which we'll talk about later.
Yes.
If the patient comes to us in crisis, where we have respiratory difficulty, patient will need a ICU care, a comprehensive team approach. They can need some immunoglobulin injections, which we call as IVIG, or plasma exchange, in which you clean the plasma of the antibodies. So these are all advanced procedures which depend on what is the stage of the patient, but certain things like symptomatic treatment with pyridostigmine, steroids, immunomodulation will be required in most of the patients.
So, three components of treatment, I believe, if I'm correct. The first part is the symptomatic treatment, where you give some medications to try and control the symptoms.
Yes.
So, essentially, these medicines work by increasing the concentration of a particular chemical in that area, and therefore, we do these tests, and subsequently, you said immunomodulation either through steroids or other drugs. So, I believe that sort of takes a good comprehensive review of what the treatment part involves.
So, Dr. Belal, I was talking about the treatment part, and I mentioned about something called as thymus gland or thymoma.
Yes.
Can you elaborate on that?
Yeah.
Do we need any sort of surgery for that, and what are the options?
So, Dr. Kapil, there is a gland inside our body which is located between our breastbone and the heart, and this is known as thymus gland. Now, this gland is involved in development of immunity, and it is believed that this is the source of the antibody production in layman terms for myasthenia. And therefore, there have been studies which show that if you are able to remove this gland by a surgical procedure which is known as thymectomy, then you might be able to help the patients of myasthenia gravis by essentially trying to cure them. So whenever we are treating myasthenia, as you said, there are two components. One is the symptomatic treatment, and the other component is try to control the immune system of the body, because it is essentially an autoimmune disease. And if we can remove that thymus gland, which possibly contributes to that immune response, then there is a fair possibility that many of these patients who are properly selected will improve in terms of both symptom control, reduce medications, and sometimes even complete removal of medications, which is known as a complete stable remission. So thymectomy is a very important part of treatment of myasthenia gravis, but it has to be done in a multidisciplinary setting where you sit in with a neurologist and decide the best line of treatment for one particular patient.
Okay. So how do you do it? You said it is behind the breastbone. So we open it up, or there is some other procedure also which can be done?
Very good question, Dr. Kapil. Actually, one of the reasons a lot of people swayed away from thymectomy, because in the past this procedure was done by an open surgery. So you used to do a cut in the middle of the chest, and you used to open the breastbone just like in open heart surgery, and then you would remove the thymus gland, which is about 15, 25 or 50 gram of fatty tissue. So essentially what it involves is removal of all the thymus gland and all the fat around the thymus gland between the breastbone and the heart. So this was a very major procedure, and it required an open chest surgery, and many of these patients, as you know, myasthenic patients may not have been very fit patients. So a lot of neurologists as well as patients used to shy away from thymectomy. But today this surgery can be done by a very advanced surgical technique which is known as robotic thymectomy. Essentially, in robotic thymectomy, we use a state-of-the-art surgical robot to make 3 small cuts on the side of the chest, and instead of opening of the chest, the entire thymus gland along with all the fatty tissue is removed by just these 3 8 mm cuts inside the body on the left side. And that leads to a complete removal of thymus gland without the need of cutting open the chest, So what it does is it reduces the morbidity of the patient, it reduces the pain, it reduces the post-operative complications like pneumonia. Patient breathe better, walk quickly, and return to their life much earlier than they would have done in an open heart surgery. And that is why today it is a very, very effective treatment for selected patients of myasthenia gravis.
Okay. So the procedures has become less invasive.
Invasive, absolutely.
And of course, if the procedures are less invasive, the morbidity is less, the patient improvement is faster, and
Yes.
results are definitely better.
And also the fact is that the patients as well as the doctor's confidence is increasing, because earlier the neurologists were quite skeptical in sending myasthenic patients for surgery, because most of these surgeries would be open heart surgery, open surgeries. But today, because the morbidity has reduced so much because of robotic and minimal invasive techniques like VATS, that even they are willing to send the patients to our thoracic surgeon.
So can we briefly summarize for a patient that what sort of evaluation or what sort of the patient will be going for thymectomy?
So what we have seen is that all patients who are between the age of 18 to 60 years, who have early onset of disease and have myasthenia gravis, they are who are antibody positive. So ACH AB antibody should be positive and MuSK negative. These are the patients who typically qualify for thymectomy. And the earlier in the course of illness the thymectomy is offered, the better the chances that the patient will have improvement. So whenever we talk about improvement, we talk about the improvement in what we call as surgeons as 1/3, 1/3, 1/3 rule. So what we believe is about 1/3 of the patients will have a very significant improvement in their symptom, and their medications will eventually stop, which is known as complete stable remission. Another 1/3 of the patients will have a significant improvement in the symptom control with minimal medications, and you may be able to reduce the steroids or remove them completely, and they will be able to lead their normal life with very minimal manifestations. And the other 1/3, unfortunately, will not respond to thymectomy. So if you look at the mechanics, nearly 66 to 70% of the patients will have some benefit of thymectomy if chosen correctly. And that is why I always emphasize that it has to be a multidisciplinary decision. I alone don't take that decision. I sit with my neurologist like yourself and then decide whether this patient will benefit from surgery.
Thank you. Thank you for emphasizing the importance of surgery and the benefits of surgery. So myasthenia gravis is an uncommon neurological disorder, but early recognition of symptoms can make a huge difference in the treatment of the patients. Treatment involves medicines. Treatment can involve thymectomy or surgery. With the proper selection of the patients, we can improve the life of myasthenia gravis patients.
Just one more thing, Dr. Kapil, we wanted to talk about thymoma. You must have seen that a good number of patients of myasthenia gravis have a tumor of the thymus gland where thymoma is there. So just to add to that word, when on one hand, surgery is a choice for patients who have myasthenia gravis without thymoma. But surgery, unfortunately, is not a choice for patients who have thymoma. And therefore, this needs to break out to the people, because a lot of people believe that if they don't have myasthenia and if they have somehow got detected a thymo tumor, it is a benign tumor and can be left alone, which is a myth that we should break completely, because it is a tumor that slowly grows inside its own space and can become aggressive and grow and invade their surrounding structures like heart and the lung. And therefore, even if it is a small thymoma, it should be undertaken. It should be taken out with the help of a surgery. And again, even in thymomas where there is a tumor, most of these surgeries are still possible by minimal invasive method like robotic or minimal invasive thoracic surgery.
So Dr. Bilal, what I understand is that if you have thymoma, surgery is essential.
Absolutely.
But if you have myasthenia gravis, you can benefit or you can need thymectomy.
Yes.
Yeah. So I think many of us are listening about or hearing the word thymus for the first time.
Yes. Yes.
So
I think it's a very rare disease, but it needs awareness, because despite the fact that it is very rare, it is still very common with us when we see at a tertiary level center. And a lot of people go undiagnosed. And I believe that this small podcast would help them realize what myasthenia gravis is. And if there are any patients, they can connect to a doctor early in their course of the disease.
thank you.
Thank you.